Welcome, friends, viewers, and colleagues, my dear friends. Welcome on MuniMeterHealth, your source of learning cardiology and, of course, enhancing medical education, patient education in order to improve the clinical outcomes. I'm Dr. Jaitly. Again, welcome on MuniMeterHealth. Just a quick few housekeeping rules. As I always say, this is purely an educational channel. It's not a medical advice, number one. Number two, if you're having an emergency, please consult your doctor right away and get to the nearest hospital. And number three, for my students and learners, this is not a substitute to your syllabus. Please note, it's a supplement to your syllabus. Okay, please stick to your own syllabi from the universities. Having delved into those matters, now let's get into the subject matter. The subject matter today we are going to be talking about is thrombolytic agents. What are they? Well, we need to know that there is actually a lytic system. We call it a clot-lytic system. That means the clot is constantly being lysed in the body. And then there is a clotting system. So these two are in an equilibrium so that the blood actually flows in a regular fluid medium, right? So the blood is flowing in the regular medium through this artery here in this fashion, depending upon what the equilibrium between the clotting lytic state is and the clotting actual state is. Okay, now so the lytic state consists of only 2 or 3 steps, so I made it easier. Basically you have a tissue plasminogen activator, we call it a TPA, and that is activating the plasminogen to become a plasmin. Remember, everything is inactive, it's being converted into active. If you remember that, that'll be great. Now plasmin then acts on fibrin. Now fibrin, which is already a clot, remember this was already a clot that has formed, and will degrade into that and therefore cause lysis here. This is lysis, and so fibrin degradation products will appear like FDPs, and this is actually dissolving the clot. So this is a dissolving clot mechanism. Now let's get to the coagulation mechanism on the right side of the panel here in the pink. So here you have an extrinsic pathway which is composed of tissue factors only, and then there's an intrinsic pathway here, intrinsic pathway which activates autogenously, automatically, and that's based on a factor 12A. Extrinsic pathway requires an injury to the artery or to the endothelial surface. I got news for you, by the way. The endothelial system is the largest organ in the human body. Everybody asks, oh, maybe the liver is the largest. No. Endothelial system is the largest organ in your body. Why? Because it's traversing through miles and thousands of miles of your arterial system. So you can imagine how much is the tissue factors being generated each time there's an arterial injury in the endothelial surface. Now, tissue factors will activate 7 to 7A. 7A will convert a 10 to 10A, 10A being the active here, and that 10, now remember, this is a common pathway. Why? This is called the common pathway. The reason it's called is because you have intrinsic pathway coming here on this side and an extrinsic pathway should there be an arterial injury that occurs. Now why should an arterial injury occur? Well, it occurs because we normally have atherosclerotic plaques as soon as we are past the age of 15. So I got news for you. So atherosclerosis is an aging process which is lipid rich and obviously has macrophages and cholesterol rich plaques. So now you have these plaques which are normally hard, but then if the plaque becomes soft and it ruptures, we'll show it in a different schematic here. If it ruptures like this, what happens? This is 3-dimensional, obviously. I'm trying to show it in a 2-dimensional arterial. So this now obstructs. So as a result, there is no flow going through the artery. That's called total occlusion. And that results into an acute MI, folks. Or it can result into acute coronary insufficiency, also known as unstable angina. A total occlusion of that artery can result into, if it occurs in the heart, it results into an acute MI. If it results in the brain, obviously it results into a stroke and what have you. Other arterial systems you can just extrapolate. So we are dealing with the heart here, so we're just looking at the coronaries here. So magnified coronary arterial thrombosis has occurred here. As a result, now a clot will start to form, and we'll show it in a different color. And this clot will develop over a period of time and then totally obstruct the artery. Now the clot consists of fibrin. Here's your fibrin, guys. Okay, and this fibrin right here. So the clotting cycles or clotting mechanisms are overpowering the lytic Autolysis, remember, autolysis normally occurs, but it's overpowering so the equilibrium has shifted towards the clotting side. As a result, this clot has occurred because of the tissue factors that have been released, or the plaque that has ruptured rather spontaneously or acutely. So remember that clotting mechanisms are now overpowering the lytic mechanisms, and that's where our role comes in, and thrombolytic agents. That's what we are discussing. So we have thrombolytic agents like streptokinase. We have thrombolytic agents like, obviously, this TPA. Now there's a recombinant TPA, or TPA we call it, or redoplase. This is alteplase, and this is streptokinase. And there is also something called urokinase. That's derived from the fetal kidney cells. Streptokinase is derived, you'll be surprised, from the hemolytic streptococci. And being outside agents, these are antigenic. Remember that. So they are highly antigenic. So over a period of time, people do develop reactions. And should you have to take that patient for a second dose, then automatically antibodies are already existing, and there might be some reaction here. So just be careful. And again, these streptokinase, these are, and the urokinase, these kinases, they are actually systemic. So anywhere they can cause a lytic process to exist throughout the cardiovascular system. So it can result into bleeding tendencies. Whereas TPA and RTPA, they require the fibrin surface. Remember, they require the fibrin surface only. So as a result, they could be acting only at the clot surface. Wherever there is a clot that has formed, it will not be systemic. So they'll be very localized. So the bleeding tendencies are extremely lessened. There is no antigenicity there, and the bleeding tendencies, as I said, both for TPA and RTPA will be RTPA even lessened here. And now the dosage, just quickly, I wanted to go over. The streptokinase requires about 1.5 million units. You can just multiply that by 6 here, and million units to be infused over 60 to 90 minutes. It is an IV infusion, whereas TPA can be given as a bolus, and you can give up to 100 milligrams rather as a bolus. Okay, so in a nutshell, you've learned about the thrombolytic agents here, folks, and essentially there is a lytic system and a clotting system that's constantly occurring existing in an equilibrium, making the blood actually flow. And if the flow is maintained, you have a normal flow through the patent artery. But the moment the stagnation occurs as a result of a rupture of plaque, the thrombus forms, and the clotting mechanisms will overpower, and as a result, the lytic process will be lessened. So now the clot forms, and as a result, now you have a clot. So essentially, thrombolytic agents will work on this clot. Specifically, TPA and RTPA will work at a very, very right at the fibrin. They interact with the fibrin surface, so that's where the clot is. Whereas this systemic lytic agents like urokinase or streptokinase, they will work throughout the system, and therefore will have more bleeding tendencies throughout the system. Okay, so in a nutshell, you learned about thrombolytic agents, and hope to talk to you again. So